I'm thrilled to be here. This audience is very important. You've been doing laboratory medicine for a long time. And this project started in 1984. So it's 28 years long. Kind of amazing, isn't it? I saw a resident when I got a page as a straight CP resident at WashU who said, I need to work up a prolonged PTT and I have no idea. And by this time, he's 8 months into his internship. And I said, so what you been doing up to now, Clay? He said, what everybody else does. I guess at the lab tests. And I said, what would you do if you had a prolonged PTT and say you knew it wasn't heparin? He said, I'd give him fresh frozen plasma without figuring out why it was. Well, it turns out that he probably gave a whole bunch of people hepatitis C, which was non-A, non-B. And at that time, it was 1 out of 20 bags. And he was killing people, and he didn't know it. And he was well-intended. And so people just assumed that if that happened, it was fate. It wasn't because there was a preventable error somewhere in this mix. I recognized that it was a problem in 1984 and tried to get the faculty at WashU to say, yes, we're going to interpret the complex cases in coagulation or other areas. And there was absolutely zero enthusiasm. The external environment was not ready. And then in 1985, I went to Penn. And I was a new assistant professor, as Dan said. And in 1987, I said, I'm the director of the coagulation lab. I'm going to take a sheet of paper, put the results in, and then at the bottom, I'm going to interpret it. And that will be after reading the clinical record, not some cookie cutter thing. I'm going to say this 12-year-old patient has. Well, that worked for about 6 months, and everybody loved it until the chief of hematology came to me and said, pathologists should not do this. And I said, isn't it helping? He said, yes, it's helping others. It's helping patients, but it's not helping our program because the way I earn money in Hem-Onc is I send the fellow to see the patient with a prolonged PTT, and if it takes a rectal exam, then so be it. All right. Well, I know how this works. There's the professor, and there's me. So then I went to the Mass General, and that was 1989, and I said, I'm doing this or I'm going down with the ship. So we started with coagulation, and it took 3 or 4 years to get everybody up to speed to get ready to hear what you got. But the bottom line is that, doggone it, we're doing it. Vanderbilt and the external environment are the reasons. After doing this for 20-some years in the let's keep trying this in this phase, the external environment has changed, and Vanderbilt has put money behind it. And in the next 18 months, we should be able to, as the chief of medicine says, DMT the entire department of pathology. So I'm going to tell you what this DMT is. I've long realized that the two big problems with regard to consultation are that doctors don't know which test to pick and they don't know how to interpret the test results. So what I'm going to do today is to talk to you about the problem. There it is, the presentation of the clinical problem. I'm going to tell you about the diagnostic management team, which we call the DMT at Vanderbilt, what it does and how it was created. Dan was here, joined us at Vanderbilt for a week and saw it firsthand. I'm going to tell you about the existing and the planned diagnostic management teams. I'm going to give you a nuts and bolts daily view of coagulation rounds as an example of one of the DMTs and add a few concluding thoughts. So first, the presentation of the problem. I learned this quickly. This is the brain of, say, a doctor in the emergency department. It could be a hospitalist, anybody who's taking care of a patient. And when I went into the clinical lab as a resident at WashU, I wondered, what was my job? I mean, the reality is the techs were doing all the tests. And I said, well, let me see. The blood comes in. It was collected by somebody else. Everybody's doing the stuff. It goes in the computer. And I'm just watching the whole thing happen. And then I realized that I actually had a huge job, and it was related to the big problem which nobody was talking about. And that was, which test do I use to figure this out? And what does a low protein S of 45% mean in a lady who's pregnant? And then I thought, whoa, that is a real job. It's distinct from what a medical technologist does, though a medical technologist could do a lot of this interpretive function, and I've mentioned that to them at their national meetings. So as you can see, the big issues here, which we're going to talk about, is picking the test and saying what they mean. This is an interesting point. The CDC has a group called the CLIC, C-L-I-H-C. It stands for Clinical Lab Integration into Healthcare Collaborative. I'm a co-leader, and the chief of family practice at the Cleveland Clinic, John Hickner, is the other co-leader. And they have us on each sides of the room, and we say, what? You know, that test you just ordered takes us 18 hours to do and costs $5,000. Whoa, I had no idea. And the people over there said, you have no idea, we need that one fast. So it was a perfect combination to say, here's what you need, and this is what we can do. Well, we're doing many projects. One is looking at physicians and what they don't know, and this is one of them, and it's headed by Brian Smith, who's head of lab medicine at Yale. And it's a survey. I hope you responded. We're getting to every medical school, we hope. And I just wanted to give you this one slide. The number of hours spent by medical students learning AP is 60 to 300 in the United States. The mean number of hours, this is now after about 60 responses, spent by medical students learning lab medicine is 9. And when they figured, is there a test for lab medicine? The answer is no in most places. And in fact, we don't even use the lab across the country. Lab medicine experts are not the people who tell you which test to pick. It's the cardiologist who doesn't know what a troponin leak is, who's giving you the lecture. And of course, then they graduate, right? And then you say, well, how many hours does a primary care doctor spend looking through the microscope? None. And how many times do they order lab tests? Every single day. Do we have this thing backwards or what? So there are efforts from the bottom up from the CLIC group, and this is just one of them, to tell you how we got in this mess in the first place. How was it all driven? Money. I mean, really, let's face it. After about the mid-1980s, if you learned AP and CP, you could look through a microscope 48 hours a week. That's the cap number for how long a pathologist works, and you can make $300,000 to $400,000 in the past 2 decades looking at anatomic pathology. And it's very tough to replicate any of that in laboratory medicine. So we became academicians, and we did not get into this same circumstance, and as a result, America doesn't have many people who specialize in lab medicine. Now, what is the landscape in 2012? Oh boy. So radiology is a diagnostic discipline, dozens of images, right? Some of us have been around long enough to remember time before the CAT scan, right? MRI, PET-G, and they're all expensive. As I tell my radiology friends, your machines don't take quarters, right? Because I always said that the lab tests were so cheap that if you put 2 quarters in, you could get your triglyceride, right? But what happened since? Well, now we're doing all kinds of tests, and I've had a whole bunch of genetic discussions today. So the problem is that, I'll take cystic fibrosis. It used to be a sweat chloride test, period. You have cystic fibrosis. Now there's more than 1,800 mutations. Does it matter which one you have? Well, guess what? In the past 6 months, Kalydeco appeared on the scene. Kalydeco is a drug that costs $30,000 per month. And if you have a gating mutation, that is one of about 30 mutations, you do not die at 37 with everybody else. That's the average age of death. And now you can live a normal life. So the question is, do we need to know the genetic answer? You bet we do. I mean, we're talking about a drug that's $30,000 a month, right? So now the whole genetic piece, it's not just a sweat chloride. Please tell me which mutation it is, and is it a class 3 gating mutation? And it's going to get more complicated than that. So the question now is, what have we been doing as a field for a long time? What we've done for years is imagine a puzzle. And we've taken the puzzle pieces in a box, right? And we've thrown them over a wall to the clinician and said, well, there it is. That's your sodium and your electrolytes, and there's your anatomic path, and there's your radiology. You put the puzzle together, okay? And for a while, they were those little kid puzzles where they were 10 pieces, you know, made of wood, right? And now with all the buildup of the lab tests, and now we have tests that cost $5,000, right? We are now taking 5,000 puzzle pieces, throwing them over a wall, and you know what the picture is? It's a snowstorm. Every piece is white. And so we're telling physicians, you do that, and by the way, do it really fast, because it costs $2,000 a day to stay in a hospital. So it's too much to ask. I think the bottom line is that we diagnosticians have to put the puzzle together. And we have to say, there it is. Okay, I'm going to tell you. Factor 11 deficiency. You don't even know what factor 11 deficiency is, do you? But I'm going to tell you, this is what it is, and that's what to do about it. And so now suddenly, where before we were kind of watching, remember I was just watching the lab test go by? Now I'm in the middle telling everybody what it is. It totally changes the way things are done. If you don't have it, doctors pick unnecessary tests, or they miss the necessary ones. It's like, I've done it this way. I've worked up belly pain with these 25 tests for the last 30 years. Well, guess what? There's one killer test now for somebody who's got this and this and this pain, and they have no idea what it is. So they're picking the wrong tests, missing necessary ones. They all come up with their different way to get there, and the correct diagnosis may be achievable very promptly, right there promptly, but it is often missed or delayed. And for the longest time, and you may have seen this recently in the Wall Street Journal, people have just chalked it up to fate. In the Wall Street Journal about 3 weeks ago, they had a thing, why are hospitals killing us? And it was an interesting story written by a doctor who talked about the failure of medicine to be transparent. That is, if you want to buy a car, you go to Consumer Reports and you read all about the car. But when you go to a hospital, you don't read about the success of procedures so easily, and you certainly don't learn about the doctors. And he tells the story of Dr. Hodad, H-O-D-A-D, and he learns that Dr. Hodad, that's not his real name, stands for Hands of Death and Destruction. And Dr. Hodad should never touch a patient. And in fact, he had more complications, more deaths and everything else, but he was a charmer. Celebrities wanted to have their surgery done by Dr. Hodad, and they had no idea, because they didn't publish the statistics, and nobody was saying anything about Dr. Hodad either. The reality is we are surrounded by people who need help, and the reality is we can be the ones to do it, and I think medicine is going to get way more transparent than it is, so we better get with it soon. So the landscape is changing rapidly, and I've been challenged to say coagulation is a small piece. Oh, if we figure out, yes, we can interpret coag, it's a small piece. If we solve it, it doesn't affect many patients. But I wanted to give you this one anecdote, and it's about Plavix. Now, there are a whole bunch of people who have stents in their coronary arteries. You probably have relatives who have a stent, right? And so when you think about what you get when you have a stent as far as treatment, it's a drug called Plavix. And Plavix keeps the stent open. No Plavix, and the likelihood that your stent is going to occlude is higher. So is lab testing important, and are the results complex? Well, it turns out that as far back as 2004, as you see in this graph looking at the high bar here, right there, that there are, at least in these quartiles, one quartile which has a low response to Plavix. And look at the y-axis. It says cardiovascular events at 6 months. So we knew that some people took Plavix and it just didn't work. And so they were increased risk of thrombotic events. So back then we could say Plavix has people who have variable responses to it. And some people take Plavix and their platelet function is good right away. Why is that? It's because the Plavix didn't work. And so what we learned since is that Plavix, also called clopidogrel, doesn't actually work as the real drug. When you swallow it, that's not the thing that's shutting off your platelets and therefore keeping the stent open. The reality is that it has to go to the liver, and the liver has an enzyme, these cytochromes, there's CYP2C19, and that makes it into the real drug, because that's what binds to the ADP receptor of the platelet and inhibits it, right? So what did we learn in 2009? A paper published in the New England Journal said, guess what? Some people don't have that enzyme. They take Plavix and it never becomes the real drug. And then somebody said, and that's why 1/4 of the people thrombose their stent. Okay, so now what do we have? Well, why don't we figure out who has the genetic abnormality that is going to let that stent get occluded, as opposed to have everybody be their own test tube? Oh, I know how we'll find out if Plavix works in you. We'll see if your stent thromboses. That's a bad idea. Could we do a lab test to find out if your stent's likely to thrombose? Better idea, right? So the fact is we started with this thing called pharmacogenomics. It's a drug and a gene. That is, does the drug get metabolized properly? And pharmacogenomics was started with warfarin. And it really, the warfarin story was kind of complicated, but Plavix was a real winner on pharmacogenomics. So what happens now is that everybody who gets a stent put in at Vanderbilt gets this genetic test for CYP2C19. And if you don't have the alleles that work, we switch you to a different drug. Now you say, wait a minute, really? You mean across the country, you got these people are getting Plavix and they're thrombosing and it's chalked up to fate. As opposed to Vanderbilt where we switch you from Plavix to prasugrel and the drug costs the same amount of money, for goodness sakes, right? Plavix will become generic, but those two drugs are about $5 a piece. So there's not even a cost penalty for doing this. Now, they also have it set up so that I see my primary care doctor and he says, Mike, you know, your cholesterol's been high, your exercise tolerance isn't so good. We're going to do your pharmacogenomics first because you're probably going to need a stent and we don't want to wait 3 days to find the answer. So the first moment we put it in, we're going to give you the right drug. Nobody's getting that. There are a few places, but the reality is across America, when you thrombose your stent, it's just fate. Nobody says that was a preventable error and it cost people their lives. So how complicated is it? So there it is. Well, allele, if you're star one, you're normal. Anything besides star one, something's wrong and you should switch. So you can see that when you give doctors these things and it says your patient has star two, they don't know what a star is. Is that like an exponent? Is it a what do I multiply it by? When you give me star one, then you say, well, it's an allele. And most doctors will ask me, what is an allele? Okay, so it's not because people aren't studying or don't know, but you got to make this practical, right? So the fact is that at coag rounds, we will say, oh, star 2, star 17, non-functional, hyperfunctional. You could use Plavix if you wanted. So there are a lot of alleles. This is a decision support. And what we learned is that we could force people to say, okay, it's star 2, you should switch. We've been watching them. I know there's a lot on this slide. They have to say why they didn't switch you. But the reality is that even with that level of decision support, they want to talk to us. What is that? Maybe because they want to learn. The other thing is that there's some special reason why they need to pick between Plavix and ticagrelor or prasugrel and ticagrelor. So I think it's fair. I mean, you know, if I have a question about my insurance or something, I'll give a call, right? Well, why shouldn't I want to talk to a real person and figure out what it is, all these star this and that? Because right now I'm just on the pick choice 1 and we'll give you an automated message, and pick 2. This is an automated message, sort of, right? And they could call up, but they really need a person. We learned more than 10 years ago, because I did this survey in 2000 roughly, that physicians benefit a lot from the interpretation of coag tests. In 2000, we did a survey of physician experience at the Mass General. We sent out 100 surveys and we said, if you remember this case, please answer these questions. What did we say? We said, did it save you time when we interpreted the coagulation test? And about 80% said yes. We said, did it impact the differential, meaning you only had to think of the 2 things maybe as opposed to 10? About 80%. It reduced the time to diagnosis. Look at these. Lab testing, medical procedures. Admissions is a low bar, but a big dollar amount, right? $2,000 a day to stay at Vanderbilt. Reduced medications, and you see the 2 bars on the right? Everybody was really worried, those hematology oncology people at Penn who said, you're going to tell them why the PTT is prolonged right away and then we don't get a consult. Yep, we did that. We were able to tell the ENT doctor, the kid has a prolonged PTT because the kid has 12 deficiency and they're not going to bleed, do the surgery right away. And those ENT surgeons were like, oh, great, I don't have to postpone the tonsillectomy. I can take they thought it was like sliced bread. It was huge, right? And did we increase the specialty consultation? Sure, because we found people with non-specific bleeding and thrombotic disorders who needed a doctor for the rest of their lives to take care of them. Finally, it worked out well in the end. Click did a project where we asked doctors from behind the glass, right? They were all out front. We asked them a whole bunch of questions that could potentially be incriminating to what we do as laboratory doctors. And these were some quotes that we got, and I think it reflects where the practice is in America. These are comments from practitioners. You don't talk to a radiologist or a pharmacist in a hospital. They know them. They say, hey, what kind of scan do I need? I got belly pain and it could be a stone. And somebody calls up and said, I do sonography and not an MRI or something. But you don't talk to the lab. Black box. Who do you get to? Who do you call up? Is it troponin leak or not? What is that? And what do I do? They don't think about calling a clinical pathologist because in 70% of America, private practice, they know anatomic path, but they have no clue how to answer a question in laboratory medicine. And there are too many mazes through the telephone. So what's the answer? So now you have the problem. Okay, diagnostic management team, what it does and how it was created. I'm going to start off by what it does and what it doesn't do. Here's what it doesn't do. A lot of people say we interpret the test results. So if you go to a commercial clinical laboratory, the commercial clinical laboratory, if I send a sample, they're my friends, right? If I send a sample to ARUP and they do a test for factor V Leiden, there's 5 sentences in there. And it says your patient is homozygous. And there's 5 fixed sentences. Doesn't matter if you're 96 years old and had a stroke, you're 26 years old and on oral contraceptives, it's those same 5 sentences. By the way, do we do that for anatomic path? Do we say, oh, let's see, ductal breast carcinoma. Let me copy the page out of Robbins and I'll just snap that baby in there, right? That is not happening. But we're okay with doing it for laboratory medicine, right? Because you get paid for saying it in AP and nobody's paying you. Forget the patient outcome for a minute, right? Are they paying us for this or not? Doggone it. Not getting paid, not saying it, because don't know it. So it doesn't consider clinical information. That's a bad thing. That's not a DMT. That's not an interpretation. You only meet for cases when you have them. Well, that's sort of self-fulfilling, right? If you only meet for cases when you have them, then you don't give them in a timely way, and people aren't going to send you the cases. The interpretation is not written. Particular finger pointed at microbiology. We walk through the lab, see that cool thing growing on that plate? Well, guess what? Let me tell you what that is. And you tell a story. Well, there's 20 people taking care of that patient. And you're only talking to 2 of them, right? And they're going to get sick later. Guess what? We had the index case for the fungal meningitis that is now in the methylprednisolone from the New England Compounding Center. And I'm going to tell you in a minute, we have a microbiology DMT. And when the person in the laboratory said, whoa, cerebrospinal fluid, aspergillus at 1:30 to 3 o'clock that day, people were sitting at the microbiology DMT saying, you get the genetics of this, you do that, and you do that. And suddenly it was spread all over the United States and people weren't giving it to people to get more fungal meningitis. That's the impact of a DMT. Whereas if you just walk through the laboratory, it's like, not my job to figure out what to do next. There are 6 people in a room and people are walking out with homework. The interpretation also can't be self-evident. Somebody in Scotland said, we interpret everything. I said, really? He sent me this many cases. I got back to my office, I saw the stuff that he sent. The first one, it was a cholesterol of 520, and there was an interpretation box. You know what the answer was? Hypercholesterolemia. I said, I'm sorry. Everybody can figure that out. Okay, so why did this project start in 1984 and really not get any traction until about 2 years ago? Number 1, why are national barriers not barriers at Vanderbilt? The first thing is they can't figure out the money. See, anatomic and clinical pathology have been tied together so much, they figure that the finances should be the same. So therefore, if I can get an anatomic pathologist to earn his or her entire salary by signing out stuff at $300 a pop, then I should do that with clinical path too. Guess what? They pay us a pittance for some of this stuff and nothing for things like interpreting toxicology. You cannot make a salary with interpretation dollars in CP. Here's the difference. When we're involved in all these cases and we go down to the emergency room and say, whoa, I know how to stop the bleeding out of that chest tube. We save blood products. We save that $1 a minute or whatever it is in the operating room and however many minutes there are in the ED. We're saving a fortune by being clinically involved, helping them pick the right lab tests and coming up with a recommendation. And the people at Vanderbilt got it and said, we need more of you folks to tell us how to deal with a lab test because you're saving huge dollars, even if we can't quantitate them exactly out of our operating budget. Almost no one understands this in 2012, and there are very few administrators in this country, the United States of America, who can figure this out and say, I get it, and I'm making the point. Second thing is it takes informatics. We have a whole department of biomedical informatics. It's separate from the hospital informatics. They built something called Quill. It's marvelous. For coag rounds, we said, these are the tests we're really interested in, and these are the drugs. It actually goes through the whole chart, and it picks out those tests, and it puts them on a separate page. so that you could actually do a complex interpretation and the resident doesn't have to sort through a chart if it were paper this thick, because they can pull it out with quill. So it's huge in terms of making it so that it's practical to do an interpretation in real time. So if it's too long to sign out a case, a DMT is impossible. We have 20 cases. I'm on service now. I have somebody doing it today as a trade, but I had 25 cases on Monday. So if I'm doing them at 20 minutes a case, I'm never getting out of the room. Okay, here's the other thing. We have said we are degree blind. That is it. Whoever knows the most, whoever can help the patient, you are in the room. And I've told this, I got to give the keynote address at the ASCLS, the American Society for Clinical Laboratory Scientists, the MedTechs, this year in Los Angeles. And I said, look, if your laboratory directors do not want to interpret a prolonged PTT, and you know how, we have to figure out how you can write the words that allows the person on the other end to get it right. And I said, who's ever willing to step up and knows it deserves to put the paragraph in the medical record. Obviously, this is a really charged point for the CAP. The CAP believes that the only people who deserve to be paid for this are MD pathologists. And I have argued against it, not only to say that a PhD, but also the new graduates who have the doctorate in clinical lab scientists. These are med techs, BSMTs that are going for doctoral degrees now in about 4 institutions, and those programs are going to grow. And even for the med tech who has the knowledge, they got to be in the room. And for coag rounds, those people are. So if payment for the consult is less relevant than the savings from getting the diagnosis, all qualified individuals should be invited. Okay. And the other is that, are we saving money? When we figure out, so when I say, whoa, you know what? I know why you haven't been able to have a baby. You have a hypercoagulable state. And that is the reason why. And I'm going to anticoagulate you for 9 months. And after 4 miscarriages, you are likely to have your first baby. How much did we save? Nah, none. Not only that, we spent more money on lab tests. And by the way, they were taking Lovenox. It would have been better if she was just never able to carry to term, right? So when you look at it, you say, we're doing huge things for patient outcome. I'll tell you in a minute. But so the health economists at the Owen Business School, right next door to the med school, have come over to help us. And I'm going to say more about that. But I want to just point out, when somebody said we can look through a microscope to tell you if that's breast cancer, nobody was asked to prove that it was better than palpation. They just said, oh, wow, we're going to look through a microscope instead of taking everybody's breast off, right? So they said microscopic is important. And when we got an MRI, nobody said, let's prove that this better imaging where we can see the adrenal gland and see if that really is a pheochromocytoma is worth it. They did it. But we are being asked to prove it. Why is it important that we have to prove that a narrative interpretation for coagulation that's patient-specific, expert-driven is going to help? You know why? Think about 70% of the pathologists in the country. How did they learn laboratory medicine? This isn't UW, it isn't Vanderbilt, it isn't the big places that do lab medicine. The person who did APCP stood behind a technologist and said, here is a thrombin time. And they learned what a thrombin time was in the lab. That is important. But the job that that person had to learn was, what is the meaning of an 89-second thrombin time in the presence of a 12-second reptilase time? And that was not taught to them. So therefore, they are in practice, they are in charge of the lab, they're getting paid for it, but they can't answer any questions. So with that, laying all the cards out on the table, the fact is pathologists don't get paid for this, and they don't want to do it because they're not content experts. And that is a challenge. Okay, how does it work? So this is Vanderbilt, that's the coag lab, and what you see here is we get samples. I'm going to tell you what the examples are from all these places. We have diagnostic algorithms. Should people remember, let's see, the PTT is prolonged, but the PT is normal. That means factors 8, 9, you can't ask them to do that. And so if you don't want to, you could go to your medical center medical board, which is what I did, and said, hey people, how would you like to order coag tests like this? One of the questions is, work up my patient for a clot. That is, hypercoagulability workup. Work up the prolonged PTT. They said, really? You guys will do it? We send one sample. You just keep doing tests, reflex tests, till you get to the end, and then I'm done, like right away? Yes. Yeah, we approve. We approve. So every time we put in more reflex tests, we had better test ordering. Every test the tech does is meaningful because it's coming in a reflex test algorithm. It's not those extra tests that mean nothing. And then there are 4 attendings. I'm one. I do 3 months a year. We give an expert-driven patient-specific interp, and we're trying to figure out how much we're saving. Now, I will tell you that this has gone into microscopic areas, and this is credit to Mary Zuter, who's was head of HemePath. Now, recently, Adam Siegmiller's taken over. Here's what happened with HemePath. The oncologist tells this story. I get a call, and the patient says, I hear there's a patient coming from Kentucky, and they have ALL. And what test do you want ordered, doctor? And they say, I want all these tests. I'll order all the molecular tests. And then the pathologist looks at it, and it's not ALL, it's AML. Now you've just done like thousands of dollars of tests for the wrong malignancy. And what I've equated this to is just take my wallet, take all the bills out, get the paper shredder, and just put them through. Because it's a complete waste. The information is totally useless. And you just spend thousands of dollars doing it. And by the way, that's over and over again. So the oncologist says, I don't want to do that. You order the test to the pathologist. What? You want us to? Yeah, just give us an option. That's when we realized that molecular genetics, as you can see here, molecular genetics, histopathology, cytogenetics, and flow are put together by the hematopathologist, and the oncologist just says, work it up. And we don't get paid for the synthetic report. So there's no payment for putting it together. But that's what they read, and that's what they act on. So we, again, are not driven by what the insurance company is going to pay, but we are synthesizing the whole picture. Now we're putting the puzzle pieces together and saying, here it is, it's AML, and it's this variety. So we have 9 hematopathologists, and this is the way they do it. It's expert-driven. Let me show you a few things. This is 2010, the prehistoric era from Dr. Adam Siegmiller. On the right, you can see that says karyotype. Karyotype, they have checks on it. Here says FLT3, that's a molecular test. And Adam has his patients blocked out here, done. Check, check, make sure you have them all, right? And then Mia Levy, who's an oncologist and informatician, said, let's put this on a dashboard. And this dashboard is really cool over here. And the oncologist and the pathologist are both looking at it. See the green boxes right there? So this said that stands for cytogenetics. Here's a fish. Here's flow, molecular. When all the boxes turn green, there's an alarm. And it goes to the pathologist who says, put them all together. Thank you very much, I got it. And the people in oncology are not calling up saying, do you have it yet? Do you have it yet? Well, it's all right there. And so this has been marvelous. They order bone marrow biopsy panel, testing panel. The pathologist orders the tests. We have our own algorithms. And the oncologist retains the option to order the test a la carte. What did we save? In the first year with 1,800 bone marrows, we spent $284 less using this, which amounted to that, $450,000. Now, if you save tests, it's easy to quantitate. So for HemePath, they said, we love the DMT. It's saving us tests. I said, well, let me tell you, for coag, we're actually doing more tests. The trouble is, we're actually telling people that they have this disorder, and we're going to treat them so they don't bleed so much, or they don't get a second clot, right? I have a 27-year-old who got a thrombosis in her head, right? If she gets her second clot, she's on Coumadin for the rest of her life. Problems with pregnancy, she's warfarin's teratogenic, she's still menstruating, she's going to bleed like crazy, become anemic. I work closely with that woman to make sure she does not get her second clot. I mean, it's those kinds of things where we've improved the outcome for coag, and it's not like this where it's clear we're saving money. Now, micro rounds. I have to say that those micro rounds has been challenging because they say, oh, it's all an infectious disease. And everybody knows how to interpret the test results. So we had a case at Rounds where there was a neurosurgeon who had a CSF fluid, never involved infectious disease, and had some horrible thing growing in the CSF. And we realized, you know what, it's not all infectious disease. The other thing that we realized is that a lot of infectious disease docs actually benefited by the knowledge of the microbiology lab director who knew something about the operational characteristics of the test. How sensitive is this? Do you need to do this? And there was no working relationship. And we said, can we do this? And so it was a little hard at first because we said, what would we interpret? E. coli urine infections? I mean, where do you draw the line? What do you interpret? For special coag, it was everything out of special coag. For hemopath, it was all this malignancy. What do you interpret for micro? So I have this one big arrow, which is infectious disease, and all the little arrows for other services. There are multiple attendings, and they actually, 3 of them show up at rounds every day. So you have a molecular person, a virology person, and a BAC-T person. So we usually have multiple attendings. We get that expert-driven, patient-specific interp. We hope to use fewer antibiotics and see if length of stay is different. But this is the critical piece. They had to tell us what they were going to interpret. Let's take a look at that aspergillus in the CSF for the meningitis case I just told you about. The text says, whoa, we got an aspergillus and it's a CSF. That's a very bad pathogen in that particular fluid. Oh boy. Any of these will kick off a DMT review. So that's how the cases appear. We have this sentinel list, and if any of these appear, they go to the diagnostic management team, and Jim Chappell runs it in the lower right there, you can see. But people don't sit in the hospital with infections that get worse and worse because it's going to the DMT and everybody is chasing down something to make it happen. Transfusion medicine rounds also exist, 3 big arrows. Here we got the ED, the operating rooms, and hem-onc for a lot of blood, multiple attendings. We get the expert-driven review. I'm going to say more about that. We hope to save money on blood products. And the other intriguing thing is I asked the anesthesiology clinical chief, do you take people to surgery with prolonged PTs, PTTs, low platelet counts, bleeding histories? All the time. I said, really? I said, don't you see them on Monday and take them to surgery on Wednesday? They go to some pre-op? Yeah, we do. I said, wouldn't it be a good idea to figure out what they had before the incision is made? How could we do that? I said, because we have a DMT. If you just draw blood on Monday, send it to the DMT, we're going to figure it out by Monday night, and then maybe before the surgery, we'll give you a factor concentrate or cryoprecipitate. And so now we're working on what we're calling a super DMT, which involves both the blood bank and coagulation. So transfusion medicine rounds, the predominant case material. It's an expert-driven consult, but the important part is it's in the chart. It is not a curbside consult. We, in laboratory medicine, do too much chatting in the hall and not enough writing in the patient's chart. And so, what are they doing? The usual things, transfusion reactions, but they're saying something in the chart. And what could you give, right? Red blood cell antibody identifications. I'm going to tell you more about coag in a minute, but you can see transfusion. What red cell antibody is it? How hard is it going to be to give blood? A massive transfusion protocol. When the cooler goes down with all those blood products, how many products were used? How many of them came back? What should be in the cooler? Whether or not somebody who is Rh negative got an Rh positive product and what we're going to do about it. Any error in real time is discussed. They're doing about 5 cases a day. And now, so that's transfusion, let me just say that we're taking heme path, and in the next 18 months, we are going to march through the cancers. So breast cancer is on deck right now. What is breast cancer going to involve? Well, we have immunohistochemistry. We have histopathology. This looks like a regular anatomic path person, right? But whoa, we got molecular in there. We got genetic stuff and cytogenetics, right? And guess what? We have a mammogram and an MRI. Now we're going to have to bring some people in the room. Who's the diagnostic people? A radiologist, a molecular person, and an anatomic pathologist who knows breast. And they're going to synthesize this puzzle piece, and they're going to hand it to the breast oncologist. And that is truly different. So it's taken, there's some political stuff we needed to champion in radiology and all that other stuff, but it is happening. So far in clinical pathology, we have coag, transfusion, and micro. We are starting interpretations for endocrine-associated hypertension, and we're going to grow from there. toxicology and autoimmunity are coming in the next 18 months. What does it look like for anatomic path? We started with heme path, breast cancer this year, neuropath, that anatomic path plus genetics, right? The glioma has certain genetics to it. We're going to do that, renal, lung, and other cancers. Now, here's an interesting idea, and the interesting idea is, shouldn't we have a DMT per disease? Because if you look at why people come into the hospital, low back pain is a big one. The trouble is, what lab tests are associated with low back pain? It's all over the place. But what the administrators said is that we are standardizing the approach to the patient. So maybe what we ought to do is, just because it standardizes the approach, we need an obesity DMT, a diabetes DMT. We haven't figured this out yet, but I thought that was intriguing. So coag rounds, how it works. At 8 o'clock this morning, the resident, Adam Johnston, went to the coag lab and said, how many cases do we have today? And between 8 a.m. and 4 p.m., Adam looked at probably 20 cases, and he read the clinical material. And his responsibility is, at 4 o'clock, he has to show up with a paragraph that says, this is my interpretation. It's not a cookie-cutter thing. He had to make it up from scratch, reading the clinical record. At rounds is the attending, the coag resident, other trainees, the technologist. Relevant teaching points are made. Here's the interp. We fix it. I usually comment on, let me tell you about Plavix pharmacogenomics. And as soon as we click done, it goes right under the numbers into the electronic medical record. June 30th, 2010. This is what they got for coag. This is an actual workup. It turns out, asking doctors, they have no idea what P plus NO hour stands for. So asking the doctors, they didn't even know what the abbreviation stood for. I said, what do you do with the report? They said, we look for the asterisks. There's two of them. One says the PTT, so I know that's long, and I have no idea what RVVT is, but it's abnormal. So, so here's what happened. We could have done on July 1st. That's the unedited canned comment. The dilute Russell viper venom, that was one of the asterisks. That thing is abnormal. So there's your canned comment, right? Here's what we really did July 1st. Your patient has an elevated PTT with a normal PTINR. Thrombotime's okay too. Because the PTT was long, we did a mixing study and it failed to correct. So we did the thing that is the most likely thing to explain a prolonged PTT that doesn't correct, a lupus anticoagulant. That's the Russell viper venom. It was positive. Taken together, that PTT is because they got a lupus anticoagulant. A neurologist called me up that very day and said, hey, Mike, I read this thing. He said, are you going to ever do that again, or was it just a one-day thing? And I said, Derek, we are going to do this for the rest of your life. And so the fact is, once we start these, they're going on forever. So who's at rounds? The trainee, usually a path resident, occasionally a heme-onc fellow. They're doing their workup, right? And this, as far as teaching, think about it. I said, what was your life before we had coag rounds? They got lectures. They got like 20 lectures over the course of a month about coag. And I said, but you didn't see real live cases in real time. I said, let's do the same thing for AP. So what we're going to do is, instead of you actually getting cases a day, like all the breast biopsies or anything, we're going to put all those away and we're just going to give those to the attending. And every so often, we're going to pull out our favorite breast cancer case and we're going to let you see that and tell you about it, but you have no responsibility and it's not in real time. What are you going to learn? And I said, that's the way people learn clinical pathology across America today. Unless your feet are held to the fire in anatomic path to say something intelligent about that sample, you can't. And therefore, if you don't do it in clinical pathology, you don't learn it either. So the med tech is there to tell us a lot of important things. The result is influenced by methodology. It's a clot-based test. It looked a little hemolyzed. Let me explain the stay clot LA, and maybe it was a clot. Now, here's an interesting thing. The librarians come to coag rounds. You saw them. So the librarians, what is that? So they said, we can really make a difference, because you ask questions halfway through. It's like, oh, wow. I'm not so sure. Are people anticoagulating for a superficial vein thrombosis? Because that was sort of in flux. So they said, we'll look that up. So then it got formal. And so they got Informatics Center, Knowledge Management. Look at this. We have our own page, Diagnostic Management Team Database. And there's a summary and there's some up-to-date stuff that we can link in. But more importantly, take a look at this. On the left, in the lower left here, acetaminophen and platelet function. We asked the question, does Tylenol interfere with platelet function? Because the current thought is that it doesn't, but there's some data that it might. They searched the literature and found it and put it in there. So then, here's our page. You can go look at, was this question addressed before, or we can ask a question and select a list of library resources. So I asked this question about superficial thrombosis. I know this is I can read this in a minute. And the bottom line is that now, yes, we are treating for superficial vein thrombosis. And if I click on this, I get the actual paper. And they give you this within 24 hours. We are working up prolonged PTs and PTTs at coag rounds. We are telling you if you have HIT or TTP, both of which can kill you. We are telling you why you had your blood clot in the lung and whether or not you need Coumadin for the rest of your life. If you have bleeding, we're telling you what the disorder is that caused the bleeding. For thrombotic strokes, we're telling you if that's a hole in your heart and you need anticoagulated as opposed to aspirin. For OBGYN, we are the first line to tell you why you might be infertile because of a hypercoagulable state. We put kidneys into people knowing if they're likely to thrombose the renal artery right after it goes in. And here's two more. One is for people who have lupus and other autoimmune disease, we find out if they're at risk for thrombosis with antiphospholipid antibodies. And for pediatrics, we go through a complete workup for the bleeding or bruised child to make sure that this was not a kid with a bleeding disorder who had a minor injury described by the father. I have 30 cases right now in my file, a whole bunch of emails to respond to. There are at least 600 men in prison right now who have kids with a bleeding disorder, and they had a minor injury, and that minor injury was witnessed only by the dad. They don't believe him. They think the dad hit the kid on the head, and they're in jail. And it's horrific. We have a non-accidental injury panel, and you don't make a conclusion about anything until you do the whole workup. As far as I know, we are the only ones doing that. Most people still have overcalls and are falsely putting people in prison. So we're not saving money when we do better, making a good diagnosis, but we are improving outcomes. From 19 days of cases, we have been keeping records for impact. I just want to show you a few. See, explained, previously unexplained. So that's why I had 16 clots. That's why I couldn't carry to term. Oh, that's why my PTT has been prolonged for all my life, right? No, you don't have a coag disorder. Your vaginal bleeding is from something other than coag. Check the endocrine story and a whole bunch of others. Changing platelets, is it a platelet problem or not? Preventing a misdiagnosis of a hypercoagulable state. The people outside of medicine, surgery, pediatrics, and everybody just said DMT everything. I mean, really, why would you take a service and not put all the pieces together? And you know, you don't have endocrine yet? You're just giving us a bunch of endocrine tests and you want us to put the pieces together? Don't do that anymore. Just DMT everything. So I want to show you some data for coag. This is done by Larry Van Horn. Larry Van Horn is from the business school, and he doesn't know what any of the DRGs are, and he doesn't know what the abbreviations are. But he did it before and after the DMT. With this series of pre and post implementation to see if the length of stay changed for anything. And he said, well, I found two where the length of stay changed. He said, I don't know if they have anything to do with coagulation. What's PE? Pulmonary embolism. Yes, that's a clot. And intracranial hemorrhage, that sounds like bleeding. That's yes. Now the intracranial hemorrhage held with non-parametric analysis, but parametric, it was just PE. We cut a day off. Look at the bottom. It's easiest to see here. So for PE, we had a length of stay of 3 days, and now it's 2. I can't get the arrow to move where I want it to move. There it is. Okay. Notice 3 and 2. So that is a huge savings. That particular thing is worth about $2,000 right there. And we were already beating the length of stay for PE. So here's what they came up with. They came up with a term. They said DMT shortens the diagnostic latency. I said, what's that? They said, here's what happened before. Tests were ordered on Monday. The results came to the doctor on Tuesday. He or she looked at them. They decided what to do on Wednesday, and on Thursday they sent you home, and you stayed 4 days. When you have the DMT, the tests are ordered on Monday. The tech works them up. They're in the hands of the resident. By 4 o'clock, they're all interpreted. The doctor looks at them on Tuesday morning and it's all figured out. They do what they're supposed to do and you're gone on Wednesday. Holy cow. So the length of stay got shorter. Here's the data. On the x-axis is total charges, so being way out on the right is bad. And the y-axis is length of stay. And the red is before coag rounds. Look how it's distributed all through there. The green is after coag rounds, and notice they're more on the lower left. So this guy cost a fortune, and he just sat there. But when the DMT came, everybody said, well, wait a minute. What's that guy doing in the hospital with his PE? So, and intracranial hemorrhage, same thing. Look at all those red dots scattered to the right. So we were shortening the length of stay. So why is it? Is it all the latency thing? Maybe, but it's also possible that they realize we know something. Every doctor at Vanderbilt said, there's somebody in the clinical lab who really knows clinical medicine. And not only that, wants to help me. And so that is totally new, and they're calling up a lot more. Our visibility has changed, so we're given more talks. And now they're getting smarter too. Oh, protein S goes down in pregnancy, and it's not a risk for thrombosis. Okay, I learned that. That's in my fact base. I don't need to make that mistake anymore. Finally, some concluding thoughts. So here we go. Are pathologists in practice willing to provide advice on test consultation? And this is the problem in America, right? It's that 70% of hospital care, not transparent, mistakes and everything else, we hide them good, right? All of that is, this diagnostic work is done by people who are making a handsome salary doing anatomic path, and they're not really thrilled about the fact that they're going to have to learn this stuff, especially the genetics. So very hard. So the people who've been practicing have said, you know, this is like the 18th time the alarm has rung. You're going to have to know more. You're going to have to answer questions in the clinical lab. And, you know, why is this different from the first 17? So nobody's really listening. The CAP has tried. Charles Roussel, who's head of the CAP, at the CAP meeting, if you went to the national member luncheon, he said, it is going to change. Do not fool yourself. You're not going to get paid the same. This is not per click medicine. The world is changing. Not that anybody believed it, but he said it. Digital imaging is changing. We never thought in the 1970s that we could automate a glucose. Could we automate the reading of a little strip of gastric biopsy? Less money for healthcare. Genetic testing is really expensive. So it could be that money will drive this thing, and there will be a major learning curve that's required to do it. So we'll see with time. Now, when I first started doing this, I will tell you it was just me. But now I'm pleased to say these are the people that run the medical center. Balzer is the dean and the vice chancellor for health affairs. Pinson is right below him. Stead is the director of strategy. Christy Sinkfield works with him. Manning controls the money. David Posh is the president of the hospital. These are the three people from PATH. Me, Sam Santoro, and Mary Zuter. There's our health economist. Those are the information scientists, the medical informaticians. We got legal people on this, 20 DMT attendings, and tons of technologists, and the trainee director is in this too. This is now a juggernaut. It took 28 years to get to this point, but in the next 18 months, I think we will have finally DMT'd all of pathology. That's the story. Thank you.
Excellent questions, I'm sure. Mike.
Yeah, I had a question. It seems like you could make a business model around this at providing it as a service to outside hospitals that have contract pathologists who don't want to do it.
Right. So good point. So Larry Van Horn said this. There's a hospital 70 miles to the east of us called Cookeville General. It has 2 pathologists. And what Larry said is that, look, if we can quantitate shortening the length of stay for a DRG, he said we could quantitate their shortening of the length of stay. So therefore, if you send samples to Vanderbilt and we do the interp, they can do the tests even. But if we do the interp and we shorten the length of stay, we share in the savings. So let's say we get 10% of those length of stay savings that are quantified and documented, right? A before and after, that it's a business model where Vanderbilt could earn money without seeing one more patient. So he thinks there's actually lots of money in this, and we haven't gotten that far to try it yet. But that is a thought, a very thought that you articulate.